Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Switzerland, Dr. Christian Eisenring, who is a federally certified specialist for neurosurgery and the recognition of diploma in Switzerland, Germany, and Finland. He has done his clinical observerships from multiple places like Helsinki, Germany, and Switzerland, and his clinical interests are focused upon cerebrovascular, spine, and infections. He has published several articles in various peer-reviewed journals, and we are extremely honored to have him today at our webinars. And today we'll be talking about the incidence and outcome of aneurysmal subarachnoid hemorrhage in Switzerland, the Swiss SOS study. The speaker for the second session of today is our honored guest from China, Prof. Tianmin Qiu. Dr. Qiu is an associate professor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai. He is a pediatric neurosurgeon who performs more than 300 surgeries per year, including tumor surgeries, neurovascular surgeries, and spinal surgeries. We are extremely honored to have him today at our webinars, and today we'll be talking about surgery of the pineal tumors in children. The chair for the first session of today is our honorable faculty from Canada, Prof. Ashish Kumar. Dr. Ashish Kumar is an assistant professor of neurosurgery in the Center for Cerebrovascular and Endovascular Neurosurgery at the Sunnybrook Health Sciences Center and University of Toronto, Canada. He was a past fellow of the Fujita Health University as well as the University of Toronto. He is a fellowship director of Advanced Micro Neurosurgery at his institution, and is also the vice chair of the Inclusion and Diversity Division of Neurosurgery. He is a part of several novel projects in his institution which has contribution to the development of professional practices. He has won the Peter Boyd Teaching Award for Best Teacher last year, and is a hybrid neurosurgeon who specializes in the management of aneurysms and other cerebrovascular diseases. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Turkey, Prof. Abuzer Günger. Prof. Günger is the professor of neurosurgery at the Yeditepe University Hospital. He is also in charge of the famous Yeditepe Neurosurgical Laboratory. He is a specialist in fiber dissection of brain and complex skull-based approaches. He has published several articles in various peer journals, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Prof. Ashish Kumar.
Thank you, Dr. Raja. Good morning, good evening, good afternoon, everyone. I know people are joining across the globe. It's morning here in Canada, so I will welcome you all. This topic actually is of particular interest to all neurosurgeons. Knowing the vascular neurosurgery interests of most of the young neurosurgeons, especially in Asia and also abroad, it's a very important topic which talks about incidence of aneurysmal SAH. There was an article in neurosurgery, if I remember, where they studied a global incidence of and prevalence of subarachnoid hemorrhage, because it has a direct implication on the extent of financial resources and hospital administration. So it is actually, it was seen on that study, if I'm remembering, that the overall incidence most commonly was reducing as compared to in early 80s and 90s. So it will be very nice to hear from Dr. Christian Eisenring about the Swiss incidence and prevalence, and also the outcome of subarachnoid hemorrhage. So I think it will be of particular interest for everyone who is involved in vascular neurosurgery and who manages aneurysms in their clinical care. So with that, I would like to invite Dr. Christian Eisenring to take over and present his data. Welcome.
Thank you very much. Yeah, thank you, Professor Kumar, for this nice introduction, and also Dr. Raya for this invitation today. It's a big honor to be here, and I try to share screen right now. So this is the presentation of the Swiss study on aneurysmal subarachnoid hemorrhage. This study has been started in 2009, the data collection, and since then is going on. Now we will see three bigger studies. The first is on the data collection from 2009 to 2015 to evaluate the incidence of subarachnoid hemorrhage. Afterwards, we see the subsequent studies. There is also one involved in machine learning, and the most recent study that was published in neurosurgery in 2023. So the first study is the whole base about the data collection and the motivation, the driving forces, and the aim of it. And the subsequent study is basically how we skimmed the most important lectures from the available data. So before the whole study started, we were left with this one. This is the global incidence of subarachnoid hemorrhage for each individual country. And basically, you can say the darker the color, the higher the incidence is. And this data, I will go into it in more detail a bit later. The data collection and publication started approximately in 1955. And the thing was, subarachnoid hemorrhage was often published. However, sometimes it was denominated as subarachnoid hemorrhage and sometimes as aneurysmal subarachnoid hemorrhage. So ASAH, aneurysm, is actually what we were looking for. And as you see, there is a white spot in the center of Europe where Switzerland is now today, and we want to fill that gap initially with the study. And in the next slide, we see how we got there. So the background, subarachnoid hemorrhage is classically because of the rupture of intracranial aneurysm. Its incidence is quite a broad range, as we have seen. It's between 3 and 25 of 100,000 person years. The data of the incidence often comes from population registries and insurance, and also from hospital data, but the definitions were not always so clear what should be included, what should not. And the current data and treatment is quite often biased because different centers have different standards and different definition of subarachnoid hemorrhage, and also the treatment and as well treatment efforts and treatment success. So in Switzerland was the aim that started in 2009 to unify all these regulations. So first we started with literature research. We just wanted to find out what was the incidence of aneurysmal subarachnoid hemorrhages in different nations, and this is basically this kind of heat map that we have seen before. And we also tried to find additional knowledge, additional data about mortality in each country, the reference population size of each country, and the monitored time, how long the supervision time was, or the follow-up time. So we found 133 studies. The average incidence of subarachnoid hemorrhage unspecified was 10,8, and of aneurysmal subarachnoid hemorrhage was 7,3. The mortality was between 4,6 of 100,000 person years for undefined subarachnoid hemorrhage, and for aneurysmal subarachnoid hemorrhage, of course, it was just a smaller selection. This was 3,1 of 100,000 person years. So this is all the compiled data. And again, we have two data sets. One is unspecified subarachnoid hemorrhage, and the other one is aneurysmal subarachnoid hemorrhage. And we see a large data trend. The incidence since the 1950s is in the trend line generally decreasing. And also for the particular subarachnoid hemorrhages of aneurysm that's depicted in blue here, we also see a decreasing incidence from the 1990s to current date. The same about the mortality. It's basically decreasing since we started to find some data in the 1970s and to now, and also for specific subarachnoid hemorrhages. This is the blue line from aneurysmal subarachnoid hemorrhages. We have a bit less data, but we also see a decreasing trend line in mortality. This is the same heat map before. This is just about the base. This is the compilation of all the data we found in the literature research. So this study is from 2012, and it informed about the aim, about the introduction of the nationwide registry, the Swiss study on aneurysmal subarachnoid hemorrhage. And now we will go a little bit more into details of this registry. So the aim was to identify the aneurysmal subarachnoid hemorrhage that are admitted to Swiss hospitals. And the first time period was from 2009 to 2014. We also collected population data, outcomes at discharge, 1 year post-discharge follow-up, and the treatment effectiveness of aneurysmal subarachnoid hemorrhage, also for endovascular treatment and surgical treatment. So this is the case report form. This is quite important because we do not only see the classical information about the patients like sex and age and admission, GCS and neurological deficits, but we also see any additional follow-up treatment like the follow-up imaging, the treatment, if it was coiling or clipping, if there was hydrocephalus subsequently, then if there was vasospasm, and of course the outcome, quite important. It was not only registered at the discharge, but also 1 year later and 5 years later with specific neurologic deficit, modified ranking scale, and Glasgow outcome scale. We will have a more detailed look in a bit. So here you see it. So the incidence rate of we registered the incidence rate, then the demographic and clinical variables that we've seen before. And I will go into details with the modified ranking scale later. That's why I wanted to show it again. So modified ranking scale of 0, this means no symptoms, as we all know. And basically MRS of 6 is basically that. And also modified ranking scale 1, this is important because it's no significant disability, but there are some symptoms. MRS 2 is slight disability, but still able to look after the own affairs without assistance. These are the most important spots. I think the WFNS classification is well known. 1 is no clinical deficit, and 5 is when the Glasgow Coma scale is below 6 and independent of motor deficits. So now we come a bit to more details. The inclusion criteria were basically all the patients with subarachnoid hemorrhage in Switzerland, because they are usually brought to one of these national referral centers. These are based in all the major cities: is Aarau, Basel, Bern, Geneva, Lausanne, Lugano, St. Gallen, Zurich, in alphabetical order. And this trial was registered in a secure trial. So then the first result. This is the first chunk of data that was analyzed in 2012. There was a majority, like known, about 2/3 of patients were female. Their follow-up rate was more than 90% at 1 year. The incidence rate, this is the magic number, so we know it now, it's 3,7 per 100,000 persons year. So the incidence of aneurysmal subarachnoid hemorrhage is 3,7 per 100,000 person year. The case fatality rate at discharge was almost about 1/5 of patient, and after 1 year it increased a little bit. Yeah. Well, here we see the mean age. We will have a look at it in further detail. We see it's 56, and this number is quite relevant, and it's the same number here. So what we see here, this is the incidence in red of aneurysmal subarachnoid hemorrhage overall, and it's detailed for all the most important 5 years of life, so 20 to 24, 25 to 29. So it's in steps of always 5 years. And we see the highest incidence is between 50 and 54 years. And this is important. This is also socio-economically important, because people with subarachnoid hemorrhage, we will see later, they will have some disability, and for some times in their life they will have a high mortality rate. That means this disease has quite a high socio-economical impact, because these people who get this disease with a mean age of 54 years, they won't be able to continue the work in most cases. And also to see the relations to the share of people with subarachnoid hemorrhage compared to the total population, we see that it's really low in the 20s. It's increasing, and afterwards it stabilizes somewhat. However, the total number of the population decreases after the age of 50 approximately. So we also see that national Swiss population, it's mostly constituted by people that are between 45 and 49 years, as an interesting information besides subarachnoid hemorrhages. So the results of the treatment, we see here nice pie chart. Most have been treated endovascularly already by that time. About one-third was treated surgically, and the remainder was treated with combined approach or no treatment. What's also quite interesting, about half of the patients, they had external ventricular drain or CSF diversion. So the next and maybe most interesting slide is the outcome parameters. And now it's important that we have repeated the WFNS classification before. So we have here poor grade, we have good grade, that would be a WFNS 1 or 2, or poor grade, it's WFNS 3 to 5, or all the patients together. And below there is a scale on the x-axis of the modified ranking scale. And as we remember, modified ranking scale is a no deficit. 1 means slight deficit. 2 is some deficit, but still able to care about oneself. And of course, modified ranking scale 6, it would be that. So we see we have a follow-up. So we have a follow-up of the modified ranking scale first at discharge, and on the second side, on the right side, 1 year later. And we first want to focus on the total numbers. So we see death, of course, it increased within 1 year, but all the other parts of modified ranking scale had a tendency to improve. We see everything that did not die kind of shifted to the left side. That means most patients that didn't die, they basically improved in the modified ranking scales. And this is the same phenomenon with the good grades, with low grade subarachnoid hemorrhages, and also those with the poor grade. We see there is some slight increase of the mortality, but all the others, let's say, worse outcomes, they improved within 1 year. So it shows there is a relevant improvement also in socio-economical functionality within 1 year. And if we take all the good outcomes, let's say modified ranking scale 0, 1, and 2, we see that about 2/3 of all patients with aneurysmal subarachnoid hemorrhage in Switzerland had a relatively good outcome after 1 year, and were in certain degree able to carry about their own. So now to the discussion. The most important point about this study was the incidence that happened to be 3.7 of 100,000. This is still in the lower end of the international spectrum, as we have seen on this map before. And these strict criteria for inclusion, and this is why aneurysm is underlined. This led to a quite a low incidence, because an aneurysm has to be seen to declare the subarachnoid hemorrhage as aneurysms. There was a trend toward endovascular aneurysm occlusion that, of course, that kept on. And as we said, 2/3 of all patients had a good 1 year outcome. Yeah. So next, we say future study will focus on improved prediction and outcome measures. And this very first study has been published in 2021. And of course, we will see also at some of these future studies that have been published subsequently, to also learn about the positive side of such a big data collection. So far, so good. I take a short break for my presentation. We are approximately halfway through. And right now we have the opportunity to ask a question if there is question about first half of the presentation. Okay.
We usually have questions at the end of the.
All right. So we just hop over this one, and then we talk about the question then later on. Go back to the presentation. Yes, here we go. So the next study, it has a very long and complicated title, but basically it's the use of machine learning to predict the outcome. So what we want to do, we want to use machine learning to predict the outcome of aneurysmal subarachnoid hemorrhage based on this data set we compiled. And this is the study that had been published in Neurosurgery also in the 2021. And I want to explain a bit in more detail how machine learning could contribute in 2021, and also will be expected to contribute more in the future once you have a solid database. So the aim was to develop a and validate the complication and treatment aware outcome prediction tool of aneurysm subarachnoid hemorrhage. And we see here, like traditionally, and this will be the early part of the study, they included all clinical data that you can collect with the admission of the patient, then also first radiological variables on admission, and also the variables basically that can be collected at the first at the first encounter of the patient. And compared to this rather traditional data set was the evaluation of also later data sets after the admission of the patient. And this is a radiological follow-up imaging and data, variables regarding treatment and complication, and additional variables during the hospital stays. And those two methods were compared with a machine learning approach regarding the outcome. And what we see, the important like late events that cannot be registered as the first encounter of the patient, this will be aneurysm rebleeding. This happened in 3.6%. Then cerebral infarction due to delayed cerebral ischemia, this would be 10%. Then new cerebral infarction on postoperative CT, 15%, and new cerebral infarction on the very last CT, this would be 4%. This is the results. So again, we focus on the early model. This is all the data that you can compile with the first encounter of the patient. And we can say in short words, this is basically what we know from previous literature. Of course, it's a diameter of the intracerebral hemorrhage. It's all the known scores like WF&S, Fisher score, and basically aneurysm diameter, things you can measure on the first encounter. This is not very surprising. However, if we include also the later data, you see the cerebral infarct on last CT. This is the variable with the highest importance for outcome prediction. That means for the prediction of a good or favorable outcome. That means modified ranking scale 0, 1, or 2. So cerebral infarct on the last CT has the biggest influence on this. And the other parameters are actually quite well known, with the exception of the BMI. And one more important factor I wanted to point out is the aneurysm location according to ISET. So it's either anterior or posterior part. But because this registry has all the information about all the locations an aneurysm can have, that means the major cerebral arteries, we can even go into more details with this evaluation. We will have a look at the subsequent study focusing on this one. So discussion. So even both the early and the late data sets, they have the ability to predict to a certain degree the outcome. And the machine learning model worked quite well. And yes, and what's important, if you can add more dynamic data, I mean, if more data appear in form of new deficit, of a new follow-up imaging, whatever, you can dynamically integrate this new data set in a patient case and at once compare it to the previous data set. And that way you have like a real-time prediction model to include all the recent events, to like have a very detailed prediction model for one simple patient or one individual patient case, basing on a whole data set to compare. And this is quite a solid base for the future development. So far about the second study. Now would be a moment for question if there are questions, but I ask you to write down the questions so we can also discuss the question about the second study in the very end. And as I said before, we will have a closer look in the location of aneurysm and the aneurysm bleeding, and also what kind of additional information we can deduct from the location on the aneurysm and rebleeding rate. So this next study was also published in Neurosurgery in 2023, and the title is Impact of Very Small Aneurysm Size and Anterior Communicating Segment Location on Outcome After Aneurysmal Subarachnoid Hemorrhage. So what, in short words, what does the ACOM aneurysm contribute to the outcome compared to all the other aneurysms? And it was to focus on aneurysm that's called small, so that would mean less than 4 millimeters, and all aneurysm were compared to aneurysm between 5 and 25 millimeters, as we will see in the next slides. Yes, this is basically the title in more detail. That means ASAH, very small anterior communicating ACOM aneurysm, less than 5 millimeters after treatment and at discharge, to compare it to like not ACOM aneurysm with either less than 5 millimeter or more than 5 to 25 millimeters. What were also included in the outcome is a new focal neurological deficit, again, the modified ranking scale as before, mortality rate, and procedural complications such as in-hospital rebleeding and the presence of a new stroke on CT. Included were 1,258 patients, 439 had ruptured ACOM aneurysm. I have depicted this 439, this would be like the blue part here. Then 384 had a very small ruptured aneurysm. That means an aneurysm less than 5 millimeters somewhere in the brain. 384, I have depicted them here. And this led to 144 ACOM aneurysm that were ruptured and less than a 5 millimeter. This is like in the intersection of all ruptured ACOM aneurysm and of all aneurysm that are less than 5 millimeters and rupture. So in the next slide, we focus on these 144 cases. After treatment, there was found a higher bleeding rate of the small ACOM aneurysms, and the bleeding rate was 2.8% compared to all the other aneurysms, and this would have been 2.1%. And particularly, the bleeding rate was even higher when endovascularly treated. That means with endovascular treatment, it was 2.1%, and with surgical treatment, it was 0.5%. So interesting fact was that the aneurysm size between 5 and 25 millimeters, that means that the not small aneurysm, was a more important predictor or more important risk factor for new focal deficit. It was much more important than the anterior location. Or in other words, the size of the aneurysm was a more important predictor on rebleeding than just the location in the ACOM region. So finally, even if the rebleeding rate was higher in ACOM aneurysms and even with the endovascular treatment, the mortality at discharge did not change. So it was comparable for both, for either the mortality and also the occurrence of peri-interventral stroke was comparable to other aneurysm of another size or of another location. This is quite interesting because even though the bleeding risk was higher, the final risk of mortality or of new stroke was comparable to the other location. And this is one particular slide I wanted to present because of this rich data set. It was possible to identify the occurrence of new stroke at discharge that has been diagnosed by CT, and also these risk factors that lead to a higher risk of a new stroke of CT. And this is basically also the known risk factor, but still good to have it in a written form. It's a surgical treatment. This leads to more stroke postoperatively on CT. It's high age, particularly more than 70 years. And it's basically the Fisher scale. That means more than 1 millimeter blood clot and an intraventricular hemorrhage. So finally, the discussion. Very small ruptured ACOM aneurysm have a higher bleeding rate, but are associated with less morbidity and mortality. And this is quite an intriguing fact. So epidemiological data found out that more small aneurysm are being diagnosed in younger patients. That means we have more cases because of better imaging of small aneurysms in younger patients that want to know about the treatment and treatment risk and not treatment risk. And this is quite important to know that on one hand, the bleeding risk is higher, but on the other hand, the treatment risk overall, it's not higher for small ACOM aneurysm. So this association is paramount when counseling patients with small unruptured intracranial aneurysms. So this was the third of the three studies I wanted to present today, we again keep the questions for a little bit later. I have just the conclusion of all the three studies regarding this Swiss SOS protocol. What I want to hand out, to take as a take-home message as a first was the collaborative effort. The first is to unify and structure data sets to also make it accessible for other people, and not only national people, but even international collaboration. Of course, it's a big benefit if you can have a look on the data and also give it out for other people to make their research or analysis on it. So if you have a new innovative approach like machine learning, you can at once compare it to an older data set that's readily available, and also compare like new treatment techniques or new surgical techniques like endovascular innovations. You always have an available data set, and you can compare the current standard to a new one. And this, of course, helps a lot for predictive models. Whenever you see a new treatment and new results, you can compare it at once, and you will also be able to, for a single patient case, for individual patient case, with every new complication or like finding that already had been registered in the big patient registry, you can adapt the predictive model, and this is a step closer to the patient individualized therapy, what's of course the future. And the final and most important thing is the treatment innovation. If we have new treatment modalities, it can easily be compared to a readily available solid database. So we are at the end of the presentation. We see there was a little bit progress during this presentation. You see here in the center of Europe is Switzerland. It has been white because we didn't know what the incidence of subarachnoid hemorrhage is. But if you can keep this number in mind, 3.7 per 100,000, made a little progress. So you see, if you compare these two slides, Switzerland is turning yellow. Thank you very much also for the other collaborator of the Swiss SOS study. I hope this collaborative effort will bring us to much more innovations in the future. Okay, thank you very much for your attention. This is it so far, and now I think you can get over to the questions.
Thank you so much, Dr. Eisenring. I will now open the presentation for questions and comments. I see Professor Mathuria, who is an expert in aneurysms and subarachnoid care in the panel. So I'd like to invite Professor Mathuria for questions and comments.
Thank you, Professor Ashish. And at present, I am in Toronto only with my daughter for a few days. Yes, yes.
Very nice.
I'll see you sometimes. And as far as it has been told that the small aneurysms are really, it's a big challenge, and yes, they cause rebleed far more than the other aneurysms. So as it has been told that in hospital bleed is quite common with the small aneurysms. What I wanted to know is that what is the time lag between the rupture of the aneurysm and the surgery or the intervention at your place?
Well, as soon as the patient arrives at the hospital, it usually takes less than 24 hours until the first operation. It depends a bit on the clinical state of the Glasgow Coma Scale, but usually it's less than 24 hours until the first either.
No, I'm not asking that. Surgical. I'm asking from the time of bleed, when the patient has bled at a place, he reaches the hospital, how long it takes, and then how long it takes for after reaching the hospital to the clipping or coiling.
Yeah, so we have a referral system that allows a referral within 2 hours. I mean, if the patient recognizes, goes to the hospital from the moment he rings, either with the primary care or like the treating physician, it usually takes less than 2 hours to reach the next possible hospital. And after that, of course, CT and everything, with the coiling, it usually is a little bit faster because they also do it during the night. Depending on the severity of subarachnoid hemorrhage, usually it's planned in an elective form the next day. So it's usually between 0 and 24 hours after reaching the hospital. the treatment.
See, obviously, it's very nice that the patient reaches within 2 hours of the bleed. That's very good. Dr. Raja, I'm just telling you that we should also try and achieve the same in our country as well. Though the thing is that as you are telling 24 hours, I was working in PGI Chandigarh till 10 years back, and we had been the largest number of aneurysms getting treated in the country. And at present also we are clipping around say 415 aneurysms a year. That's what is the record. That is about the clipping only, and maybe another 200 getting coiled. So that's the structure in PGI. But the say the treatment time in PGI used to be about few hours.
Few hours,
few hours. We used to operate the patient within 4 to 5 hours, starting from 7 a.m. to say about 6 p.m. or 8 p.m. We used to clip the aneurysm before 9 p.m. Then we used to start it back at the 7 a.m. That's what was the thing. Because the reason is, as early you clip or coil, that early you can start the anti-vasospastic treatment, and the other things also can be quite nicely taken care of, because you are told that the infarct is quite a lot, 10.5, 10%. That can be reduced by doing that. So that is one thing, and obviously the public awareness and everything, obviously that goes on. And the other thing which I wanted to tell you is that you talked about the modified Rankin scale, you talked about WFNS, but there is a Hunt and Hess grading also. There are old-time people like me who used to practice Hunt and Hess grading, because if the grading is done by a neurosurgeon, then Hunt and Hess grading gives you a very good clinical profile. If you if you read about the studies by Dr. Takanori Fukushima, when I spoke to him, he told that the best prognostic grading is the Hunt and Hess grading. That's what you used to do. Then you were telling about the poor grade. Poor grade, we should try and differentiate between the grade 4 and grade 5, because the prognosis is different in grade 4 as compared to grade 5. And I am really pleased that your prognosis in poor grade is quite good. The last question and comment is, now what percentage of the aneurysms are being coiled? What percentage are being clipped in your country?
This is a really good question. The numbers that I have shown you, these were up till the year 2015. And in the year 2015, I would have to check it again to make sure I'm telling the right numbers. This was, here we go. So yeah, it was almost half have been endovascularly coiled in 2015, but I'm sure it decreased to about 2/3 by now. It's not yet part of the registry, but this is what we see in everyday life. It's 2/3 or even more are being coiled nowadays.
We must have a very good collaboration with the endovascular people, and we should decide that what is the indication for a particular lesion and particular patient to be done. That's the best way it should be done. And after all, the patient comes to a neurosurgeon, so it is our responsibility to provide the best possible treatment to the patient.
Yes.
That's all, Dr. Ashish. Thank you very much. I took a long time.
No problem, Dr. Mathuria. It was great to have your comments, and I saw it afterwards that you are also in the panel. That's why, otherwise I would ask some of the opening comments also. Thank you so much for your comments. And now I have Professor Abuzar Gungar. I think your hand is raised. If you want to go ahead and unmute yourself.
Okay. I want to congratulate you to collect this huge data set. And I want to ask, do you have any recommended model to decrease the mortality and morbidity? Because it is still high.
What you say, which model?
No. Do you recommend any model to decrease the mortality and morbidity after this study?
It's a very good question, because we know about 1/5 of patients do not even reach the hospital. They usually go, they die unnoticed. So it's very difficult to decrease this number. Once it's in the hospital, well, you know yourself. I mean, we just try the best to do as early as possible imaging and as early as possible CSF diversification. It's very difficult to predict the outcome. The third big morbidity besides hydrocephalus and rebleeding is of course vasospasm, and we also treat it sometimes with intravascular dilation.
Thank you.
The best way to reduce the mortality is public awareness. Now the patient comes at the earliest possible to the hospital, and we should try and provide the treatment as early as possible, so we reduce the rebleeding rate, because rebleeding is very common within first 24 hours.
Mm-hmm.
And then we can start the subsequent treatment. Because say it's very much painful to any neurosurgeon that the patient comes to the hospital and then he rebleeds. And within 24 hours, say, as the patient you are getting in 2 hours, if we treat it at the earliest possible, before the vasospasm sets in, the mortality will be reduced quite a lot, even the morbidity also.
Mm-hmm.
So it should be the earliest possible we treat, the earliest possible we get the patient, that will reduce the mortality.
Thank you, Professor Mathuria. Dr. Eisenring, I have a few questions based on your stages of discussions and presentations. So, the overall incidence in Switzerland, what it seems that it is low, right? It is around 3.2, if I'm not wrong.
Yeah,
2.7.
correct.
So I was mentioning about that article, which was I actually found it on JAMA Neurology. It's a systematic and meta-analysis of all the worldwide incidence of subarachnoid hemorrhage, and they collected the studies from 1960 to 2017. So it's an extensive data, and it showed the incidence reduced, from morbidity reduced because of improvement in treatment options and modalities. But the overall incidence world over reduced, except for Japan, where it actually increased. And I think this is also very, very well known that in Japan and in Finland, these are the two geographical areas where the incidence of subarachnoid hemorrhage is very high. And I think most of us who have gone and observed surgeries in Japan, they know that they have a very high clipping rates for unruptured aneurysms. Like you will find every day there will be a patient with a unruptured aneurysm in the operating room. And I used to wonder, sometimes it's a 3 millimeters one and a 4 millimeters one. And they're very small. Normally, you don't see these patients, small aneurysms, unless they rupture. But there is actually a national screening program, and they identify them and they treat them because of this high geographical incidence. So I think that is a very important part of the study when you actually assess the overall incidence in the study. But do you think there is any risk factors or any particular geographical factors in Switzerland which actually contributes to them? Like, have you studied in the same paper, there was an association with high blood pressure, smoking. I think this is also a very important data which goes hand in hand with the incidence of subarachnoid hemorrhage. Do you think any local factors influence this incidence?
Of course, the incidence of smoking in Switzerland decreased massively since the 1980s. And I think this also explains why this incidence of subarachnoid hemorrhage is quite low. And on the other hand, it's quite a mixed population in Switzerland. And this also contributes that genetic factors are not as impressive as in a rather homogeneous population like in Japan or maybe Finland. And the other thing is the increased incidence in Japan could also be possible because there's of course better imaging, and if you have better resolution, you rather see small aneurysms bleeding and define it as such if you have the imaging methods to diagnose it.
Correct. Yes, Dr. Mathuria.
Say, a little lighter note, Japan, because Professor Hirotoshi Sano, he is there. I call him Professor Yassergil too. That's what is Professor Sano. That's how the incidence and management. In Finland, Professor Juha Harnesniemi.
Yeah.
That's how the things are. And in Japan, the incidence, you are telling about the unruptured aneurysms, way back, say somewhere in 92, 94, when I had been to Professor Kawase, they had an insurance program in which the MRI, in insurance program, the MRI and MR angio was covered. So that is how they had the incidence of unruptured aneurysm detected quite early. And they followed them up, and then they subsequently clipped them. So that is how the say the treatment rate of small aneurysms, unruptured aneurysm, is quite a lot in Japan.
Yeah.
Please go ahead.
If I may
And,
say something, Prof, as Prof. Mathuria said that awareness is very important as to the public, but I would like to say not only to the public but also to the doctors also, because for most of the physicians it is stroke anywhere in the LMICs. It may be ischemic or hemorrhagic. It is a stroke unless otherwise proved. So for detection of aneurysm and to even look for a CT angiogram for the location of aneurysm is very important. The awareness should be in the general medical group also. And also about, you talked about Prof. Sano, who is popularly known as the White Jack. He is a wonderful
Yes.
person. And regarding Japan, as you said, this is covered under insurance there, because after the success of the Nijindoc system, where every person would undergo systemic investigation to detect cancers in other organs, they followed the brain doc system. So all these various hospitals have this empaneled centers where they can walk in and have an MR angiogram taken. That is how such high grades, high incidence of detection is there. So I think our national policies in LMICs should be more concentrated on this area. But as you said, incidence of aneurysmal hemorrhage is pretty high in India, I would say. But the
Actually,
treatment and yes,
the
yes,
thing is, we should try and convince the healthcare takers in the government. We should tell them that, say, this is a disease which can lead to disaster if it is not taken care of on time. If we detect an aneurysm unruptured, the mortality is very, very low.
Correct.
Because that time it is a lesion. When we detect it as a subarachnoid hemorrhage, then it is a disease, it is not the lesion. So if we tackle it as a lesion, when it is unruptured, the patient is cured. Once it is a disease, subarachnoid hemorrhage, there are complications of subarachnoid hemorrhage itself, not only the aneurysm. Then we are treating the subarachnoid hemorrhage. So that's what should be emphasized to the government and everybody. And say we belong to the country, the neurosurgery, where Professor Ramamurthy started. He told at district level there should be a neurosurgeon. When we used to get in PGI, when the aneurysms were not being clipped outside, we used to get the patient that, sir, we have seen a patient of a subarachnoid hemorrhage. We have done the, CT angio. CT angio shows the aneurysm. The patient will reach you in 5 hours. Please keep the OT ready. That's what should be the awareness to the public and to the surrounding doctors at the district level. That's what we should achieve at every place in the world. What to talk of India or Switzerland or Japan or Finland. That's what we should be. Because once the aneurysm is clipped unruptured, it is cured. Once it is clipped early without complications, then also it is cured. A disease which is a disaster can lead to a cure. If it is detected on time, it should be told to the government at every place that they should pay a special attention to it. That's what should be the thing which we should be doing. Otherwise, it's not a justice to the management of subarachnoid hemorrhage or the aneurysms as such. That's what I'm sorry, I'm a bit emphatic in what I'm talking, but it's really bad if we are unable to manage these patients on time.
Yeah.
No,
So yeah,
Professor Mathuria, it is actually because of your interest in the subject. So I anticipated that. So I'm actually very thankful for your comments. Yes, Professor Eisenring, you wanted to say something?
yeah, I want to summarize it. It's the question of the health insurance and also the referral system that improves the treatment quality of non-ruptured aneurysms. And there's two things to Professor Raya. We have two more questions in the question and answer below. The one
Yes,
is
yes.
what
Yeah,
criteria? Oh, sorry. Yeah.
You may
What
answer that.
criteria you use to decide for surgery versus coiling endovascular? I think it's international standard by now to have this interdisciplinary neurovascular board, and this is exactly how it's happening. Yeah, that's how we do it as a case depending. And the second question there, I would be glad to have some other opinion as well. Did you have post-coil recurrence, regrowth, and needed clip, and vice versa? So post-coil recurrence, this actually I've seen quite a few times, regrowth and needed clip, and yeah, this happened. What we do in our institution normally, we put a first clip and remove the coil surgically, and then put a second, a definitive clip. I think this is quite a well-known strategy. However, the vice versa, that would be a post-clip grow and then coiling. So I'm not sure about what your experience with that, but I do not have much experience with that happening. Does it happen in your institution? How do you treat it?
No, what's the question?
If you have
Dr. Mathuria is about what is the incidence or what is the management strategy for post-clipping recurrence or versus also for post-coiling recurrence. So an aneurysm which has been coiled, and when you want to go and clip it again, what is the incidence and what is your experience in that? And also the vice versa thing, like a patient who has been clipped and there's a recurrence and now endovascular treatment is being offered. So that was the question.
yes.
See, post-clip recurrence and endovascular treatment I am not aware of, but post-coiling, say the recurrence is it's far more common than post-clipping recurrence. And post-coiling recurrence nowadays there are so many. Say I'm really sorry to say for say including me, that what innovations the endovascular people had, we did not have in the clipping much more.
Yeah.
Say they have got lots of things, and they are able to do the second procedure and do it. If it is not, then what we have to do is that, as you already suggested, that we have to put the clip, create a space, remove the coils, and then only do it. So that's the way it should be. But about the post clipping and then recurrence and coiling, I don't know. If anybody knows, then should be, because we didn't have such patients. So that was the reason.
Yeah, that's why they said like once patient is clipped, it is cured. Once patient is coiled, he ends up in a lot of follow-ups. I just have one related question with your, and probably my last comment also in relation to your study, Dr. Eisenring, the clinical implications. So if you have low incidence, what is your threshold for treatment? Like if you find a 2 mm aneurysm versus if you find an 8 mm aneurysm, what are the clinical implications in Switzerland? What's your threshold when you say, okay, now we should treat it? I'm talking about unruptured aneurysms detected incidentally. How do you manage that?
Well, there are many different scoring systems that you can take along. For example, the phases score. However, in the end, it's patient individualized decision. So, for example, if a patient comes again and again because he also feels kind of anxious, but he has like comparably small aneurysm of about 4 mm in cerebral media artery, both is possible. But if it has a certain psychological impact, then we also include it in the decision making. And of course, if you call the patient in a regular rhythms, like every 2 years, every 5 years, to come and discuss the aneurysm again, with each encounter, the probability increases that the patient wants to get it done once and for all. So it's some tendency to maybe over treatment, but on the other hand, it's still I think it's justified because the opposite, the opposite risk could be quite devastating. So I think it's justified.
Yeah,
See,
here,
if the
go ahead.
aneurysm is 7 millimeter or less,
Yeah.
and not in the ACOM location or not in the bifurcation location, either basilar or the carotid bifurcation, then probably we can wait. If there are no other comorbidities like smoking, hypertension, diabetes, any family history of aneurysm and all those things are there,
Yeah.
then the things are different. But the bifurcations and the locations at the ACOM, and if there is a problem with the circle of Willis, that there is a dominance on a particular side, then probably we may have to clip or coil early, otherwise may not be. And this is, I think, probably the waiting period may be much more with the MCA aneurysms. There, the bleed rate is comparatively less. So that's what the protocol we follow. And then we keep on doing now the CT angio, MR angio, we can keep doing and follow the patient. If we think that the follow-up is difficult, the patient is from periphery, he is not a complier, then probably we may have to clip that early. So that's how it should be, because we should try and see that the lesion there doesn't get converted into a disease. That's what I want.
Yes, that's an important point for young neurosurgeons. ISUIA study is the study which Professor Mathuria is referring to. 7 millimeters and above, the risk of hemorrhage becomes high, like 0.5 to 1% per year, and less than 7 millimeters is low, like I think 1/10 of the original incidence. So normally here also 7 millimeters. That's what we follow here in Toronto as well. Like anything which is less than 7. But in my practice, I've tried to see, whether 6 millimeters and 7 millimeters are in the same age, range, because it depends on also who is reading the study, like whether there's an inter-observer variation. So I give that 6 millimeter benefit, and I actually offer them that if you want to get it treated, yes, but anything 5 and less, we wait. And as Professor Mathuria said, we do MR angios once every year, and they go into the surveillance arm, unless they had a very significant risk factors, or unless I remember a 4 millimeter we treated because patient was a nurse and they were very, very anxious about, the repercussions. They have seen it. They did not want, they could not sleep. So the psychological impact is a very, very important factor. But again, these are very, very rare cases, and are exceptional rather than that. A very, very enriching discussion. I have one hand.
Then the comorbidities and ACOM location, bifurcation location, and then the family history, those things also matter. There we have to treat the aneurysm early. If we think that it is small, but it could be a blister, then obviously it has to be an emergency. Means not.
I have Dr. Opara. Go ahead. Your hand is raised. You can ask question.
Yeah, thank you very much, Prof. And thank you for the presentation. I just noted something in the epidemiology you gave from the study in Switzerland. You mentioned that there was a higher incidence in females. And I would have glossed over it, but that seems to be a quite high incidence, over 65% in the study were females. And I was just wondering, did we identify any risk factors for this?
Yes, in fact, it was 65.5% in females. Well, risk factors, I just know basically the survival in females is actually better. Even if they have a higher incidence, the mortality is lower. Well, this is all I can say about the risk factor.
Okay, so we didn't really identify any particular things that could have explained the higher incidence in females. Okay,
that's a
thank
good
you.
question. Yeah. It's a good question. I mean,
Dr. Opara is a current fellow with Prof. Kato. I understand her concerns. Thank you very much, Dr. Opara, for joining. So, Ashish, we can have the concluding remarks.
Yes, I mean, I think we had a very good discussion about the incidents, the natural history, treatment modalities. It generated a lot of thoughts and comments from everyone on the panel. I'd like to thank Professor Mathuria, and I'd like to thank Professor Eisenring for bringing all 3 studies in one short presentation, so that everyone was aware of the different ramifications and implications of the incidence and prevalence in Switzerland and the machine learning model. So thank you so much for your time today, and I'd like to thank all the panelists for their questions and comments. Professor Raja, over to you.
Thank you.
Thank you very much. It was indeed a very fruitful session, and we had very, very useful insights from very seniors like Prof. Mathuria and all. So now I'll move on to the second session, and we have very good, interesting speaker, Prof. Tianming Q, who is a renowned pediatric neurosurgeon. I would like to hand over this podium to Prof. Abuzer Gungur, who is the chair for this session.
Yes, I want to thank the ACNS education team to give this chance to share this important lecture from the expert in this area. The Pineal region is a challenging location because of its deep location, and it's surrounded with the important neurovascular structures like thalamus, brainstem, and galenic venous system. Also, it is more challenging in the pediatric age. And also, I want to listen, Professor Shortaming. Please, you can continue, Professor.
Okay, thank you very much, Dr. Raja and Dr. Gwanga. It's my great pleasure to give my presentation. It's my second time here, and thank you very much for giving me the chance. And I am a pediatric neurosurgeon. Can you see my slides and hear me well?
Yes.
Okay, thank you.
Yes.
Okay, the pineal region tumors are very common in children. So there are a lot of studies, research about the approach to get this region in the past 100 years. So today I will show my small experience about the surgery, especially about the different surgical approaches to the pineal region in children. The Descartes said that the pineal gland is the principal seat of the soul because it is very deep-sighted. And this is the basic anatomy of the pineal gland. And here at this region, there are different kinds of tumors. There are totally 5 different types of the tumors. The most common in children is germ cell tumors. And the second one is a pineal parenchymal lesions, including the pineocytomas or pineoblastomas that is very malignant. And the third one is a pineal interstitial lesions, including the gliomas or ependinomas. And the fourth is the meningiomas, and the fifth are others from maybe some other metastatic tumors. This is the pathology types in our hospital in the past 5 years. And the clinical presentation for these children, including the increased intracranial pressure and the paranoid syndrome, and also some children will suffer from the motor dysfunction, ataxia, and also they will have some problems of the endocrinopsis. And this is the clinical presentations in our hospital. So on the UMass neurological surgery in the 7th edition, there is a one flow diagram summary of the pineal region tumor management. I think for this kind of lesions, our surgical strategies are basically on the serum or CSF markers, and also whether the child had hydrocephalus at the same time at the admission. And this is anatomy from sagittal view. Let's see, this is the pineal gland. And also we can see the deep vein system around the pineal gland. And also we can see the superior and inferior colliculus just inferior to the pineal gland. And also this is the brainstem, and this is the cerebellum. And this is a plenium of the corpus callosum. So this region is very deep-sighted, and also very important structures around it. This is the coronal view. If we cut the internal cerebral vein from here to here, we can see the pineal gland. And this is the superior colliculus and this inferior colliculus. And in this figure, we can see the blood supply to the pineal region. This is the medial posterior choroidal artery. And we know that most of the lesions here are supplied by the medial posterior choroidal artery. So in the surgery, usually we have to control the bleeding from both sides because the lesion blood supply by the medial posterior choroidal artery. And also we can see this is the internal occipital vein, and this is the internal cerebral vein. And here we can also see the basal vein of the Rosen cell. All these deep veins we should protect during the surgery. Nowadays, we have about 4 surgical approaches to this region, including posterior transcallosal approach, and also the posterior transventricular approach. And also we use the occipital transtentorial approach. And also sometimes we use the infratentorial supracerebellar approach to this lesion. Later on, I will show a different kind of approach in the cases by myself. And this is the history of the pineal region tumor section. About 100 years ago, Harvey Cushing do the surgery for the pineal region tumor. At that time, they did not know the anatomy at that region. So at that time, he just do the bilateral temporal decompression for the pineal glioma. And about 8 years later, Fedor Cross, he is father of the German of neurosurgery. He did the SCIT approach, that is infratentorial supracerebellar approach. He opened the posterior craniotomy and used this approach to get region. And several years later, Walter Dandy did this kind of surgery using the transcallosal interhemispheric approach. This is he published the paper about this approach. And also Dr. William, he did this kind of surgery, used the transcortical transventricular approach. And in 1966, Dr. Popham, he used the occipital transtentorial approach to get this region. This is the figures at that time did by Professor Cross in 1912. He opened the posterior craniotomy, and also he cut part of the cerebellum and to see the lesion and resect it. And he also did a lot of contributions in neurosurgery. And at that time, several research about this approach, they find the vein of Galen. And about several decades after Cross, Dr. Steen published one paper. He used this approach for 6 cases. And in 1995, Dr. Steen and Dr. Bruce, they published this surgical approach for 160 cases. And also Dr. Brew is the writer of this chapter in humans neurosurgical. And this is Dandy. At that time, he did some research of this approach in canine and also in human. And this is the figures he published in 1936. At the time, he used this approach to get the tumor. And also Dr. William, he did the cortical transventricular approach. And this is Popham. He used the occipital transtentorial approach. But at that time, this approach, he usually approach to the lesion beneath the occipital pole. But nowadays, we usually recheck the occipital pole, but not in the same position. Next, I will show different kind of cases by different approaches. First, I will show the case of infratentorial supracerebellar approach. This is anatomy. We see that the lesion always beneath the deep vein system. We can see this is the vein of Galen, and also we can see the blood supply from both sides. Sometimes we will do this kind of tumor resection under endoscope. This is a real case. This is a 17-year-old boy, headache. At that time, we can see that the beta GCG is very high, but AFP is normal. This is the CT image at that time. At the admission, in admission, we can see that the lesion was enhanced, very severe. And we can see the lesion on coronal view. And also, this is the sagittal view. We can see the vein of Galen in the internal occipital vein and the internal cerebral vein is just superior to the lesion. And also the lesion invasive into the posterior part of the third ventricle. So our preoperative diagnosis is NGGCT. This is a mixed GCT. For this case, I used the endoscope to remove the lesion using the supracerebellar infratentorial approach. Let me show the video here. First, I open the system magnum to release the CSF. And for this approach, we have to sacrifice the superior vein on the vermis. And then we can go deeper and deeper. Now we get to the progeminal system. We can see the lesion here. As just now I said that the blood supply is always from both sides, the medial, posterior, choroidal artery. So for this kind of cases, I usually control the blood supply from both sides. This is the left side, and just now is the right side. And when we remove the lesion piece by piece, and when we get to the superior part of the lesion, we have to get the boundary of the lesion superiorly to the deep vein system. Then we removed tumor totally. And we can see through the third ventricle. And also the MEP and the SPE were protected well. And this is the postoperative CT scan and the MRI scan. The lesion was gone. The patient suffered very well. So for this kind of approach, I think we can use the gravity assisted. We can release the CSF, and all the blood supply and the CSF goes down. And also the cerebellum goes down. We can get a very clear view on the superior space of the cerebellum. And we can get a locate from midline very easily. And sometimes we can use the unilateral approach to get to the lesion. And we can operate under the deep veins. We can protect the deep veins well because the lesion is just under the deep veins. But sometimes we will find that if the intracranial pressure was not controlled well, we have very narrow space on the cerebellum. So for this kind of surgical approach, we have to control the intracranial, and also we have to sacrifice the superior surface veins of the cerebellum. And sometimes we cannot go very deep to the supratentorial space. And this is the disadvantage of this approach. Secondly, I will show the transoccipital transtentorial approach. This is the anatomy. Because we expose the lesion from the lateral side, so this is the deep vein, and this is splenium. In this approach, usually we can protect the splenium of corpus callosum, and we can get to the pineal region under the splenium. And this is the surgical view. Let me show my case. This is a 9-year-old boy. this is a very complete case. This child did not come to me at the very admission, because at that time he went to other hospital, and in other hospital they give the child gamma knife. After gamma knife, we can see the lesion a little bit decreased, but the patient had hydrocephalus. And then they did the VP shunt for this child. And after the VP shunt, the lesion goes a little bit large because the gamma knife just have the effect very, very short time. You see about 4 months after the gamma knife, the lesion a little bit increased. And about 6 months later, the lesion increased very severely. As you know, that this is mixed GCT, and also you see the lesion much larger than before. So when the child came to me, I first led our neuro-oncologist to see the patient, because this is a secreting type of mixed GCT. So the neuro-oncologist gave the child the chemotherapy. After 1 cycle, all the tumor marker goes down, but the lesion did not decrease. You see, about 2 months later, after 2 cycles of the chemotherapy, the patient, the clinical worse and worse. And also we followed up MRI, showing that lesion a little bit larger. So the chemotherapy did not work. So I have to remove the lesion, even though the lesion was so large. And also I worried about the lesion very adhere to the deep vein system, because the patient got gamma knife. So for this lesion, I used the leptopropen approach with the modified Parker bench position. And before the craniotomy, I cut the tentorium. You see, this is the lesion. The lesion is very tenacious. It's very large. So this space, I think, is exposed very clear. And this is the video of the surgery. This is the straight sinus. Here, this is straight sinus. I cut the tentorium just along the straight sinus, and to get a very clear view of this approach. After that, we get the tumor. You see, this is very hard and very tenacious. The blood supply is not so abundant, but the lesion is very hard. I removed it piece by piece. And you see, this is the posterior wall of the third ventricle. After I removed the lesion, the third ventricle, the wall of the third ventricle was protected well. And then we see the CSF. So the tumor was totally removed. This is the pathology showing that it is a teratoma. You know, this case is a growing teratoma syndrome, because the chemotherapy killed all the tumor cells that secreting the AFP or beta HCG. And then the remained tumor cell was the teratoma. This is the SEP and the MEP. This is the postoperative CT scan. And this is postoperative MR scan, showing the lesion was totally removed. But after the surgery, the patient had a very severe situation with intubation. About 1 week later, the patient recovered. And this is the MRI image 1 year later. So last month, the child came to my clinic room. He recovered very well, and the lesion was also very, the MRI image is very stable, and both the AFP and the beta HCG were normal. This is the child he had go back to school. So for this kind of surgical approach, I think we can get a little bit wider space because we can cut the tentorium and we can reject the occipital pole and get a very clear exposure. But for this kind of approach, usually I will remain the lumbar puncture before the craniotomy because when you remove the bone, I open the lumbar puncture to release the CSF, and I can get a very, very good intracranial pressure. And then I can reject the occipital pole. And also here, usually we have non-occipital bridging veins. Sometimes we can meet some very small bridging veins. We can sacrifice it. And we can get a very better exposure of the deep veins. And also we can get a very good exposure of ipsilateral side. But for the contralateral side, the exposure was not so good. So sometimes we have to get very poor exposure for the contralateral lesion. So usually when we use this approach, I usually do the ipsilateral approach if the lesion is large on the ipsilateral side. For example, if the lesion is larger at the left side, and then I use the left side open approach. And also sometimes if the lesion is very large, it will invasive to the corpus callosum. At that time, I have to open the splenium of the corpus callosum. But usually I will not open the splenium. But if the time of the tumor resection is very long, at that time, you reject the occipital bone, the occipital lobe a very long time, maybe you will damage the occipital lobe. The thirdly, I will share some experience using the posterior transcallosal approach. For this approach, this is the anatomy, and this is the splenium of the corpus callosum. For this approach, usually we will open the splenium of the corpus callosum because for this kind of lesion, it is always invasive to the very deep to the third ventricle. At that time, we have to sacrifice the splenium of the corpus callosum. Let me show my case. This is a 14-year-old boy, headache and vomiting for 1 month. This is the CT scan showing the lesion at the pulvinar, a very huge lesion, very severe hydrocephalus. And the lesion also invasive to the pineal region. And this is a T1 image, and this is T2 image, and a very severe edema. And this is a T2 flare, and this is enhancement of the lesion. This is the sagittal view, and you see the edema into the corpus callosum. And also we can see that the lesion invasive to the thalamus, and it is ipsilateral rolling to the right side. And this is MRS showing very high ratio of choline over NAA. So our operative diagnosis is a high-grade glioma with very severe obstructive hydrocephalus. So our surgical strategy, including 2 steps. The first, we do the third ventriculostomy and also the septostomy lucidum. And then we do the step 2, tumor resection. And this is the step 1. We do the third ventriculostomy and to release the CSF. And the hydrocephalus is much better than before. This is postoperative CT scan showing the ventricle is smaller than before. The patient's headache relieved. And the step 2, I will do the tumor resection. For this case, I use the right longitudinal transclosal approach. And this is the images during the operation. You see, firstly, I exposed the splenium of the corpus callosum, and I open it, and then I can get inside to the lesion. And this is the video of this case. And this is the occipital vein, and this is the parietal. This is occipital lobe, and this is parietal lobe. And then I rechecked the occipital lobe, and this is the splenium of the corpus callosum. For this case, I have to sacrifice the splenium. After open the splenium, I get to the lesion. The lesion has a very severe blood supply because this is a high-grade glioma. I have to control the bleeding from the ipsilateral side. You see now the blood supply is better than before, but when you go deeper and deeper and go to the contralateral side, you will see that the blood supply is very severe. And when I remove the lesion piece by piece, and at last I totally remove the lesion, okay, let's see the, this is the pathology showing that it is a high-grade glioma. And this is MEP. Almost for all the children, I will use the MEP and the SEP to monitoring all the motor function. And this is the postoperative CT scan. And this is postoperative MRI. And this is enhancement. We can see that all the lesion was gone. And this is sagittal view or MRI. But you see, this is the infarction on the medial surface of the occipital lobe, because during the tumor section, I have to sacrifice the blood supply here. So at the same time, maybe I sacrifice some blood supply to the occipital lobe. But the patient has no very severe deficit, and the muscle strength is at the same as before. But the deep sensation a little bit decreased. So the patient had some problem on walking, but about 1 month later, the patient recovered well. So for this surgical approach, we can completely expose the third ventricle because I goes a little bit anteriorly. Because I just rechecked the occipital and the parietal lobe, I have no damage to the hemisphere. And I can indicate it for the tumors that located above the tentorium, especially for the lesion invasive to the ipsilateral hemisphere. I can use this approach. But for this approach, sometimes we have to damage the parietal bridging vein. But for this case, very fortunately, I have no damage. We have never meet the parietal bridging vein. And sometimes we will injure the parietal or occipital lobe. For this case, I have some, the patient has some infarction on the medial surface of the occipital lobe. And also we have to open the corpus callosum. And sometimes we will meet the deep vein. We have to go through to the lesion beside the deep veins. For this approach, we have to meet the deep veins because usually the deep veins is just on the surface of the lesion. We have to protect them well. And for this approach, we have very poor exposure of the pineal gland and also the superior and inferior colliculus. And the fourth approach is the transventricular approach. For this case, I have no experience because I think this approach, we have to damage the surface of the cortex. So I never use this approach. So I have no case for this approach. You see, we have to, we may damage the phonics and we have to injure the cortex. So I never use it. But nowadays, sometimes the lesion is very large. We cannot use the three approaches above to remove all kinds of lesion. So sometimes maybe we will use variety approach. For this case, this figure is showing the paramedian supracerebellar approach to get more contralateral side. And this variant approach is the supracerebellar transtentorial approach. When you expose the superior space of the cerebellum, if the lesion is a little bit high, we have to cut tentorium from inferior to superior. When you cut the tentorium, you can get more superiorly. So this is the variant of the SCIT. And also sometimes if lesion goes to both sides, for example, the lesion is very huge, not only to the ipsilateral side, but also go to the contralateral side. At that time, you use the transtentorial, occipital transtentorial approach. You cannot go very far to the contralateral side. At that time, you have to open the felsin, and then you can get more space to the contralateral side, and you can remove the lesion to the contralateral side. This is the Baratan approach for the occipital transtentorial approach. And sometimes we will combine the supracerebellar infratentorial and the occipital transtentorial approach. For the lesion goes very higher and also at the same time goes very low. So at that time, maybe you will use combine for those different kind of approaches. I think we have to focus on these problems. The first, we have to know the relationship between the tumor and tentorium. It is very important. If the lesion is very low to the tentorium, at that time I think I will use the occipital transtentorial approach, because from superior to inferior direction, we can get to the lesion. If the lesion a little bit high, or the lesion is very go through to the posterior part of the third ventricle, at that time I will use the supracerebellum infratentorial approach, because for this approach, I use the direction is the from inferior to superior, from posterior to anterior. So the relationship between the tumor and the tentorium is very important. The second one is the relationship between the tumor and the veins. If the veins is superior or just superiorly around the tumor, we cannot use the occipital transtentorial approach, because you may damage the veins. Well, at that time, I will use the SCIT approach, just now I showed in my first case. The third thing is the tumor growth pattern. It is unilateral growth or bilateral growth, or just a midline. If the lesion goes unilateral, at that time I will use more the transtentorial approach, because the occipital transtentorial approach is usually advantage for the lesion just to go unilateral. The T2 image showing a lot of information about the texture of the tumor. It is hard or not. And also we have to give the strategy. If whether we just do the biopsy, or maybe we should do the gross total resection, it is different. For the germ cell tumor, especially for the pure germ cell tumor, usually we just only do the biopsy. You do not have to do the gross total resection of the lesion. And sometimes when you find that lesion goes very anteriorly and also very severe hydrocephalus, At that time, I prefer do the endoscope surgery. At the same time, I do the third ventriculostomy, and at the same time, I do the biopsy using the endoscope. Is a germ cell tumor, especially for the pure germ cell tumor, we will let the patient go to the chemotherapy or radiotherapy. You just solve the problem. But if it is a mixed germ cell tumor, we can do the tumor resection grafts totally. And if the lesion is very large, I will prefer let the patient to see the neuro-oncologist, whether they can do the chemotherapy to let the lesion growth decreased. If we can get for the chemotherapy, they can let the lesion go smaller and smaller, and then I do the surgery safer. And also the angle of the tentorium is also very important. It is flat or sloping. For sometimes, if the angle of sloping, I will not use the CIT approach because you will get this kind of direction from very, very inferior to the superiorly. Sometimes you will use very long equipment because it's very, very deep. And also the direction is not so good because you will find that you will very tired to do the tumor resection. And also the seventh, I think the favorite of the surgeons is also very important. You prefer the microscope or you prefer the endoscope or you prefer the exoscope. So I think for pediatric neurosurgeons with a better grasp all the skills, including all these scopes, and for different kind of lesion, we can use approach. We can use different kind of applications to remove the lesion because you know you will meet different kind of lesions. You cannot use only one approach to remove all the lesions. So for SCIT approach, I usually use the exoscope because if you use the microscope, you will your hands will go very, very deep, and for this direction, you will feel very tired. But when I use the exoscope, I just put the screen here, and I can go very through into the third ventricle, and you will feel that very tired, I think. So this is my team, and I think for the children, not only our neurosurgeons, but also the neuro-oncologists, the radio-oncologists, all of the teamwork can.
Thank you very much, Tang Ming. You explain a very challenging issue and explain different kind of approach to reach this deep-seated area, not only pineal lesions, also thalamus. And maybe Professor Mathura want to add something?
It's an excellent presentation, Dr. Tianming. And say approach by approach, I'll just maybe not the repetition, but just telling the advantages of this. There is no doubt that the Krause's-Steen approach, infratentorial supracerebellar approach, is an excellent approach for children, because the reason is that the length is very small as compared to the adults. That is one. There is no retraction of the cerebellum, which is there of the occipital lobe in the occipital craniotomy approach. Then only thing is about the air embolism. That is something which is bad, and it is a narrow space. About the occipital transtentorial approach, which you have told, what we should do is that, as in the book by Apuzzo, third ventricle book, surgery of third ventricular tumors, there the chapter is written by Professor John Jane. In that, the position is like this, that the ipsilateral side is down. So once you have opened up the quadrigeminal cistern, the occipital lobe falls down at its own. So the occipital lobe retraction is very less. And there is no doubt that this is a phenomenal approach as far as the area of exposure is concerned. It's a large area as compared to the narrow area in the Krausenstein infratentorial supracerebellar approach. That is something which is good. And you are already told about the lumbar puncture or ETV or putting the shunt for the hydrocephalus on the opposite side, so that will make the occipital lobe lax. So there is no doubt about that. You told about the von Wagner transventricular approach. About that, you told that you don't have experience. Actually, in that, we have to go through the lot of cortex or anything. Because the reason is, if there is a large tumor which has come to the lateral ventricle mainly, then this approach is indicated. Or you are just taking a biopsy of the tumor which is coming mainly to the lateral ventricle. There it is indicated. Otherwise, for the radical removal of the tumor, that's not the approach proper, because you are not going straight to the pineal region. So that is something, that is there. So transcallosal approach, again, if you are able to put the ipsilateral side down, the retraction of the parieto-occipital region is less, then it is okay. Otherwise, the retraction is quite a lot, and again, it is quite a narrow area, and you come along with the deeper veins. So that is something, and it's a excellent proposition of all the approaches. Oh, very nice. Thank you very much.
Thank you very much for your comments. I also always think about the problems you said just now. Usually, for my team, I never use the sitting position for SCI approach. Just mention that for this position, usually we will meet the air embolization. That's a very severe problem. So for me, the SCIT approach, I also use the park bench approach. You see, the park bench, the 4/4 of the park bench approach, I just raise the head of the patient, and also I can get a very, very good retraction using the gravity of the cerebellum. But the head is not so high, so I never meet the air embolization using this approach. This
Actually,
is
the air embolism, if your anesthetist is very confident to have a good
right.
monitoring and the management of that, in that condition, the sitting in with infratemporal supracerebellar approach, it gives actually the retraction is not at all there. That is something which is very great about that.
Yes, that's right. So usually during the operation, I always communicate with the anesthesiologist, and I always ask them about the situation of the patient, the situation or something, or carbon dioxide, or it is or normal or not, and they always communicate with me. So we have a teamwork. This is CIT approach. The second one, you just mentioned that the transventricle approach, if the lesion very huge, invasive to the ventricle, I think we can also use the transventricle approach. But I think there's one problem here because the lesion origin from the pineal region. So if we use the ventricle approach, you cannot control the blood supply at the very beginning. So I seldom use that.
Yes, that's correct.
Because so for me, control the blood supply is my first step. Always. So using the SCIT approach, I always control the blood supply from both sides because the median posterior choroidal artery from both sides. If I use the OTT, the hospital tentorial approach, I also cut down all the blood supply is ipsilateral side. But when I remove the lesion deep and deep, when I go to the contralateral side, I think the blood supply is severe and severe. Then I have to do the boundary, to go boundary of the tumor, and then I can get to the blood supply for the contralateral side. So that's my opinion.
as some it is very dangerous to use a sitting position if you don't have a good anesthesiology team.
Yes,
And
yes, right.
also, I want to ask some question
Yes.
about your craniotomy for also supracerebellar, also posterior interhemispheric approach. Do you use burr hole above the sinuses or contralaterally?
Of course, I will do the bone flap contralateral about 1 or 2 centimeter to the contralateral side from the sagittal sinus for both sides. Here maybe for example, when I use the hospital tentorial approach, I will the bone flap about 4 to 5 centimeter ipsilateral tight and maybe 1 or 2 centimeter contralateral side to the sagittal sinus. And also I will talk ocular as well, and also the transverse sinus as well, to expose all the sagittal sinus, ocular, and the transverse sinus. Then I can open the dural and retract the dural very clearly to open this space. Not only the space between the falcine and occipital lobe, but also the occipital pole and the tentorium. So I can put a very good exposure for this side.
Thank you, because it is important for young neurosurgeons. And one more question about the lumbar drainage. Do you use lumbar drainage? Of course, you don't need for supracerebellar approach because you open the cisterna magna first. But for posterior interhemispheric approach, because you couldn't release CSF from the pineal quadrigeminal system, for my cases, I always use lumbar drainage for posterior interhemispheric or transcaudal approach. Do you use?
Yes, I use the lumbar drainage. When I do the tentorial approach, and also when I use the transclosal approach, I usually put the lumbar drainage before the craniotomy. But for SCIT approach, I will do not this lumbar puncture because I can open the cisterna magna to release the CSF.
But if there is obstructive hydrocephalus because of the pineal tumor, it is always, and there is a hydrocephalus already because of the obstruction, it is better to do ETV or a shunt rather than doing a lumbar drainage, because then it can sometimes the lumbar drain may lead into problems, because if it is obstructive hydrocephalus, then it's ETV as you have described is a better procedure.
Yes, right. I agree with you. I prefer the ETV because I seldom use VP shunt because I don't want to put something in the body of the child. Yeah, and the ETV can almost solve all the problems, especially for the pineal region tumor because the obstructive hydrocephalus. And usually I will do the tumor section maybe 3 to 5 days after the ETV. Yeah,
that is good.
Even though I do the ETV, I will also put the lumbar drainage even though I do the ETV, because you know the ETV let the CSF go through all the CSF space. And
once you have done the ETV, then you can do the lumbar puncture, but not without doing ETV, putting the lumbar.
I cannot do the lumbar.
Yes, you can't do it. Yes.
But you know, when I do the lumbar puncture, I just close it after I do the drainage. I just close it. When I open the dural, I open the drainage.
Yes, that's correct.
Yes. Thank you for your comments.
Prof, there are 2 questions in the chat box.
Okay. Let me take a look. The position of veins in relation to tumor decals for superior or infratentorial approach. I think when you do the both approach, you can sacrifice the veins. When you do the SCIT approach, you can sacrifice the veins on the superior surface of the vermis. But when you go deeper and deeper, when you meet the rostrum cell deeper vein, you have to protect. The rostrum cell, the basal vein of rostrum cell are on the both sides, but not on the medial. When you get to the basal, the basal vein and the vein of Galen, you have to protect. All of other veins you can sacrifice. When you do the transtentorial occipital approach, you can sacrifice the bridging vein on the occipital lobe. But at that time, you have to protect the cortex very, very carefully. Because if you sacrifice the bridging vein on the occipital lobe, and also at the same time, you have some damage to the occipital vein, occipital lobe, at that time, sometimes you will meet bleeding after the tumor section on the occipital lobe. That's my opinion.
The second one.
For the second question, do you use
posterior 7 centimeter? From occipital lobe to 6 to 7 centimeter, you do not find a bridging vein there. There may be a bridging vein towards the tentorium that you may have to sacrifice, but towards the fox, towards the sagittal sinus, there is no bridging vein from the occipital lobe, so there is no problem in that.
Very seldom case you will meet this kind of bridging vein. Very seldom. I meet only 2 cases. I meet the bridging vein from the occipital vein to the sagittal sinus. At that time, I feel I will try to protect them, but I cannot do it, this surgery, because you cannot retract the occipital lobe get a very good exposure. You have to sacrifice. But when I cut the bridging vein after the surgery, the patient is well. So at the same time, you have to protect the occipital lobe very carefully. So very seldom, I only met 2 cases, the bridging vein on the occipital lobe to the sagittal sinus. Yes.
And there is one more question from the audience about the second case, which you perform a transcallosal approach. Why didn't you prefer supracerebellar transtentorial approach with endoscopy assistance?
I think if the tentorial is very flat, it is better. You can get a very good exposure using the SCTIT approach. But if the tentorial is not flat, I suppose it's very difficult to use this approach. But no angle. I cannot tell you the angle. These 2 approaches, you can see the MRI image. Yeah.
Well, Prof. Gungor has published a very interesting article in JNS that incision on the tentorium to save the bridging veins. If Prof. Gungor can enlighten us, please.
Yeah, in our philosophy, we must protect whatever we can, and because of this, we try to preserve all bridging veins. The first step is using the lateral approach, because if you use the median approach, you must sacrifice the bridging Vermean veins. But if you use a bit lateral approach, paramedian approach, without sacrificing the Vermean bridging vein, you can reach the pineal region. And also, we described a tensile cut technique. First, we described the tensile bridging veins and its tentorial sinus. Then it cut the tentorium to release the bridging veins, and we can continue our approach without sacrificing and without giving any injury to the veins. I think we can describe more technique to preserve these veins. I know you don't face with any complication related with the vein sacrification, but as our philosophy, we must protect whatever we can, because of it, we are trying to describe new techniques. Thank you. I
Yes.
think that if there's no more comments, you can close the session, Raja.
Okay, thank you very much. It has been a really nice session and we learned a lot today. So I'll close this webinar officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kaito. I would like to thank both the speakers of today, Dr. Christina Isendring and Prof. Tianmin Q, as well as the chairs, Prof. Ashish Kumar and Prof. Abuzair Gungur, for the time and support for ACNS webinars. A special thanks to all our panelists, especially Professor Mathuria sir, who joined us from Toronto today. A special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel, and he has just updated that there are around 350 people who have joined us live on WeChat, YouTube, and Zoom. So until we all meet tomorrow online, it is bye bye from all of us. Thank you very much for joining.